Hello students, this is Dr. Ways and welcome to your lecture on the thoracic wall. So with every chapter we'll start with the outside of the body and then work our way inside so that you can start to get an appreciation for the surface landmarks that are associated with the underlying organs. And this is going to be really important for your physical exam, clinical correlations portion of the course that will teach you some of the physical exam techniques that you're going to get next semester and hopefully allow you to apply some of the anatomy we're learning to the actual surface of the body. Because if you think about it, when you see a patient, you're generally not going to see what's inside. So you're going to have to rely on these surface landmarks in order to infer what is on the inside, so you know what you're listening to, know what you're palpating, know what you're observing when you are with the patient. So let's start here with the this first picture that shows what we've talked about in the asynchronous weeks with your sagittal line. Only here they are calling it the median line or mid-sternal line. And then you go to either side of that, and those would also be sagittal sections, but more specifically, you look, they're right in the center of each one of the clavicles. So we call those mid-clavicular lines. And that's going to be a clinical term that you're really going to have to know. Mid-clavicular line, mid-sternal line, and know which structures are associated with that. Because in your physical exam lab, you'll have a workbook, and it's going to tell you how to do these physical exams and where to put your hands or where to put your stethoscope. And when it says MCL or mid-clavicular line, you should know where that is. So another important one is going to be your mid-axillary line. So if you look at this picture here, right here is the axilla, the armpit, and the line that goes right down the middle, down the lateral portion of the body, would be your mid-axillary line. And then just anterior to that, you see the anterior border or the anterior axillary line, and then the posterior border or posterior axillary line. And then down here we have the opposite side. You see that it's still divided into three sagittal lines, but since we're looking at the back, we can't call them mid-sternal lines or mid-clavicular lines because you don't have clavicles or sternum in the back. So what we're going to refer to them is mid-scapular lines because they're right in the middle of the scapula, and a posterior median line. But we can also call it mid-sagittal, but you'll probably hear posterior median line more clinically. All right, so moving on to some more landmarks. Here, right in the center, you can see this in both the male and female patient. You have the jugular notch, also known as the suprasternal notch or just the sternal notch. That's going to be a really important landmark because you usually, when you're doing physical exam, start there and then you move down until you hit what is called the sternal angle. All right, and the sternal angle, also known as the angle of Louis, is really important because at that angle is where your second rib is located. All right, so if you find the sternal angle, which is going to be a bump on the chest, so I recommend practicing on yourself, practicing on each other. Find that sternal angle, move your finger over to the left or to the right, and you'll be on the second rib. Then if you go down a little bit, you'll see that there's not a bone there. It's going to be more soft space. And in that soft space, that is going to be an intercostal space in between the ribs. So again, sternal angle, second is associated with the second rib. Below that would be your second intercostal space. So another thing I want to bring up at this point, I might say it again later, but the ribs are numbered, of course, 1, 2, 3, 4, 5, and so on. The intercostal spaces, or those spaces between the ribs, are numbered, of course, between the ribs, starting with between rib 1 and 2. So the first intercostal space is after the first rib. The second intercostal space is after the second rib. Third intercostal space after the third rib, and so on. All right, so remember that when you are counting ribs and counting intercostal spaces, where the rib is and where that intercostal space is in relation to the rib. All right, other important landmarks, you'll see of course, the sternum. We've already been talking about that. and it ends in your xiphoid process. All right, and your xiphoid process is the most inferior portion of your sternum. But as the rib line and the costal cartilage comes up and it forms this angle, we refer to that as the infrasternal angle or subcostal angle. All right, and so it follows all the way down to rib 10 right here at the bottom. So your costal angle right there. And if you feel along the rib line, the cartilage line here, you are feeling what's known as the costal margin. All right, the costal margin on either side. So it'll be following the cartilage down along the ribs. That's your costal margin, and when they come together, that is the costal angle. All right, and finally, if we look at the bottom picture here, a lateral view of the human, what they're showing here is basically the anterior to the posterior, and what structures in the anterior portion are related to the structures in the posterior portion. So if you look at the manubrium of the sternum, or the top part of the sternum, and follow it back, that's associated with the third thoracic vertebrae. So when you're feeling the manubrium, you're at about the third thoracic vertebrae in the back. If you find that sternal angle or angle of Louis and follow all the way back, you're at about the fifth thoracic vertebrae. And if you go all the way down to the Zyphosternal Joint, which is the joint between the sternal body and the xiphoid process, look, you are right at the border between the bottom of the heart and the top of the diaphragm. All right, so at that Zyphosternal joint, you'll be right at the border of the heart and the diaphragm. And if you follow that back, you're at thoracic vertebrae number 9. So what that should tell you, if you're thinking forward on this, is that anywhere between T4 and T9, or T5 and T9, that's where your heart's going to sit. Anywhere between T5 and T9 is where your heart's going to sit. So if you're looking from the back and you're trying to assess, did that gunshot wound enter? Where did that gunshot wound enter and what might it have hit? If you figure out that you were between T5 and T9, pretty good bet that it might have hit the heart if it's on the left-hand portion of the person, of the patient. So I want you to start to get an appreciation for, again, what landmarks are and what's lying underneath, and how you can start to put those together to, get a good picture of what's going on inside of your patient. So now that we've gone over the surface anatomy, the skin of the thoracic wall, what is it that's immediately underneath? So this slide is going to be titled the fascia of the thoracic wall, or that connective tissue that kind of supports and holds the thoracic wall together. So just underneath the skin, you have this layer of fat, adipose tissue, that is known as our superficial fascia. So it's not just connective tissue that you usually think of, like that tough fibrous connective tissue, but it also contains a lot of adipose tissue for insulation. All right, underneath that we have our muscles of the thoracic wall, as well as the bones, and in this case would be the ribs. Then of course more muscles. Then on the inside we have kind of two different types of membranes here. The one in yellow that you see coming around here just before you hit the blue, just after the rib here, that is called the endothoracic fascias. And endo meaning inside, thoracic, so inside the thorax fascia, as opposed to the superficial fascia on the outside. So that would be immediately lining the thoracic cavity wall, and in direct contact with the next layer, which would be our pleural membranes. All right, and the pleural membranes, of course, you have the visceral pleural membrane. I'm sorry, not the visceral. That's the parietal pleural membrane. Parietal. Then you have the pleural cavity, and of course the pleural cavities have serous fluid inside of them, so that the two membranes that are part of the pleural membrane system can rub across each other without much friction. And then of course we have the visceral pleura, or visceral pleural membrane. And of course visceral means organ, so that is always going to be the membrane that's directly attached to the organ, and in this case that organ would be the lungs. All right, so we're not going to talk about the lungs, and we're not going to talk too much more about the pleura in this talk, but I do want you to be familiar with those different fascia layers that lie underneath the skin. And next we have the dermatomes of the skin. And you notice that in this it's covering not just the thoracic cavity, but also, I'm sorry, the thoracic wall, but also the cervical region, as well as the lower limbs and upper limbs, lumbar, sacral, and coccygeal. So the thing with dermatomes, they're literally just a map of where the nerve endings go to on our skin. So if you remember back from basic neurology in the asynchronous weeks, we have our sensory receptors embedded here within the skin. All right, in this case, you know, they're showing T10 dermatome, which would be right about here. I'm going to erase that. And so that dermatome would be associated with the 10th thoracic nerve coming out of the spinal cord. All right, and we know that sensory information comes in and goes through the dorsal portion of the spinal cord, synapses, all right, and that was covered in the asynchronous weeks as well. And then you have a motor neuron that comes out and goes to the motor, or the muscles that are associated with that skin receptor, that skin surface receptor. And so dermatomes are a map of where all of the nerve endings associated with skin receptors belong, and which spinal nerves they come from. And myotomes would be which muscles they go to. So throughout this semester, we're going to cover, you know, different spinal nerves and which muscles they go to, and which skin areas of skin they come from. So it's important to be familiar with these dermatome maps. Now, in your physical exam class, you're going to find that there are key dermatomes that you need to really know and be responsible for. And why? Well, C3, of course, describes is the location of the proximal part of your neck, or the root of your neck. So that's a really good landmark that separates where the neck ends and the thoracic area begins. T4, if you look at it, is the right at the nipple line here. So a good landmark. You know that if you're at the nipple line, that's T4. You got this T4 spinal nerves coming to that area, or the nerve endings from the area going to the T4 spinal nerve. T10, which is your umbilicus. T12, which is your inguinal region. So T12 right here, inguinal. C6, which goes to your thumb, middle finger, and index finger right here. C7, which then goes to basically your middle finger as well, so the other half of your middle finger. C8, which goes to your ring finger and your pinky finger. L4, which goes to your, look down here, the medial side of your leg, lower leg and foot. L5, which goes to the anterior or mid-dorsal part of your foot. Remember, the dorsal part of your foot is the top. The plantar foot is the plantar portion is the bottom. so the mid-dorsal part of your foot and the anterior portion of your leg. And then S1 right here, which is the lateral portion of your foot. And you can see those maps on the back as well. And, you know, if you look at this, it's kind of confusing to look at, like, why is it organized this way? And it makes more sense if you look at this guy who is in a bent position. It goes in order: C2, C3, C4, C5, C6, C7, 8, T1, and so on. So, you know, if you look at evolutionary history, and if you see that, you know, originally everybody is supposed quadrupeds, and then we evolved into bipeds, but we still maintain the same dermatome pattern. That's why it's organized the way it is. All right, so now we're going to look at the skeletal framework. In other words, what are the bones associated with the thoracic wall, and how do we talk about them? Now, I'm not going to go over too much about this in lecture here, but you're going to get to, you know, see ribs on skeletons, skeletal models, see disarticulated ribs, and you'll have to know the different parts of the ribs. So if you've noticed so far, anything that I highlight, in this case it would be gray, are items that you need to know. And these come from your structure list. A lot of them come from your structure list for the anatomy lab portion of this class. But what I do want to point out is that, of course, there are 12 thoracic vertebrae, and therefore if each rib is connected to a thoracic vertebrae, there are 12 ribs. All right? You have 1 through 10, which are connected to the sternum by cartilage, either directly, which is ribs 1 through 7, and then you have your false ribs, which are connected not by their own cartilage, but to indirectly to other cartilage that attaches to the sternum. That would be 8 and 9, so those would be false ribs. And then there are 2 ribs that are not connected to your sternum at all, directly or indirectly, and those would be your floating ribs. So you have 3 false ribs and then 2 floating ribs, which makes up 5 altogether. And you can categorize those 5 as all false ribs, but 11 and 12 are strictly floating. Other things to point out are that your sternal angle right here is at rib 2. We've talked about that. As far as surface anatomy goes, you can literally feel those things. Your xiphoid process right here, that is at rib 6. So when you feel your xiphoid process, you know if you go straight over, you are running your fingers along rib 6. And then the inferior costal margin, which is this area right here, that runs along rib 10, which is the last of your false ribs that are not floating. All right, so rib 10 is what is the bottom of your rib cage proper that's still connected to your sternum indirectly. All right, we talked about intercostal space numbering. All right, so if this is rib 1, this is intercostal space 1. If this is rib 2, that's intercostal space 2. Rib 3, intercostal space 3, and so on. And usually we're when we are looking for intercostal spaces, we're looking at places where we're going to place our stethoscope to listen to the heart. And you'll talk about this in clinical correlations, where to place a stethoscope, what those things are called. And we'll go over that, I think, once we get to the heart as well in lecture. So the way we refer to that is if we are in our second intercostal space here, left sternal border, that is the way we talk about where specifically we're located. If it were the right intercostal space, second intercostal space, right sternal border would be over here. Third intercostal space, left sternal border, and so on. It would be the way you'd properly talk about those areas. As far as connections go, the head of the rib is always what's connected to the vertebrae. All right, so here you see the ribs connected to the vertebrae, or more specifically, the head of the rib connected to the vertebrae. And I want you to notice that the attachment of the ribs is between two vertebrae. All right, so the attachment of this rib is between the two vertebrae. So which vertebrae does the rib belong to? Well, it turns out that if this is rib 5, then the vertebrae that it's attached to is vertebrae 4 and vertebrae 5. Of course, thoracic vertebrae 4 and thoracic vertebrae 5. All right, so the bottom articulation of each rib attaches to its own vertebrae. So if it's rib 5, the bottom portion of that rib is attaching to thoracic vertebrae number 5, and that's how rib numbering goes on and on. So, you know, the rib is technically just above 5 and just below 4. Rib 5 is just above 5 and just below 4, and that would happen for all other ribs as well. All right, so moving on to the sternum. Again, you have to know these parts, so you know they're on your list, your structure list, so make sure you're able to find them in lab. But I just wanted to point out again the sternal angle here, and the sternal angle is made from the joint between the manubrium of the sternum and the body of the sternum. So that's why it has that characteristic bump appearance or palpation when you are feeling for it. And at the bottom here you have your Zyphosternal Joint, all right, between the body of the sternum and the xiphoid process of the sternum. And then on each side, of course, you have articulation points for each one of the ribs. And notice that ribs 1, 2, 3, 4, 5, 6, and 7 have direct attachments to the sternum via their own cartilage, whereas ribs 8, 9, and 10 attach to the cartilage of rib 7. So that's why we said it has an indirect attachment to the sternum. And why they're called false ribs instead of true ribs, which are for the first 7. The first 7 are true ribs because they're directly attached to the sternum through their own cartilage, and since 8, 9, and 10 are not, we call them false ribs. So as I was going through this presentation, I noticed that there are some things missing from this presentation that are located within the PowerPoint slides, the lecture PowerPoint slides that you have access to. One of those things is there should be a little kind of star or explosion right about there at the angle of the rib. And the reason why that's present there is that's the most common area that's broken in ribs. So when we talk about rib fractures, we're talking about when, you know, the bone of the rib gets cracked. And of course, this is, like we said, one of the more common areas that are broken. And usually they're not that big of a deal. You know, there's nothing that can really be done for them. Just rest and, you know, not move around too much or breathe too heavy because it hurts really bad. I broke ribs when I was in college doing stupid things, wrestling with buddies. But when rib fractures do become an issue is when there is a massive fracture that you know, breaks into fragments and has a potential to puncture organs. And one of those types of fractures is called a flail chest. All right, so like let's say there's a motor vehicle accident or a baseball bat, took a baseball bat to the chest and the ribs got broken into fragments. And when you breathe, when you inspire, the fragment portions kind of move inward while the rest of the chest moves out. But upon expiration, the rib fragments move outward while the rest of the thoracic cavity wall moves inward. All right, and that produces what we call a flail chest movement. It's kind of flailing in a different direction, the opposite direction of where the chest is moving. And if I remember, I'll try to find a video that shows this and post it in Canvas as well. So check that out, what it would look like in a real patient. All right, another term you should be familiar with are thoracic apertures. All right, an aperture is simply an opening, and you have two apertures for your thoracic wall. There's the superior thoracic aperture and the inferior thoracic aperture. All right, so between ribs 1, between left and right, first ribs would be your superior thoracic aperture, so the opening. And if you notice what goes through that opening, of course you have pleural membranes, and the apices of the lungs would go through there. So in physical exam lab, when you're listening to the apices of the lung, you're literally going to put your stethoscope above, clavicles would be right around here. You're going to put your stethoscope on the other side of the clavicles and listen for that apical lung sound. All right, so that's something you can practice on yourself. Actually, take your stethoscope, put them in your ears, and put it on your just on the inside of your clavicle there, and take a deep breath and see if what you can hear, because you'll be practicing that on each other as well when you get to clinical correlations. And if you don't do it there, you're definitely going to do it in physical exam lab. Also, what goes through the superior aperture are your major vessels that are going out to your head and going to your arm. We're not going to cover them now because that's going to be more appropriate to cover in cardiovascular, but that's what would come out of the aperture, as well as your trachea and esophagus, of course, which would be the tubes for breathing and eating. Your inferior thoracic aperture goes all the way around, follows the rib line, and is lined superiorly by your diaphragm. So even though it's an aperture, it's an opening in the bottom portion of the rib cage, it's always going to be covered up by the diaphragm. And so that would form the borders of the inferior thoracic aperture. All right, as for the muscles that are attached to these bones, there are several you should be aware of. And I'm going to point out a couple that are not as important, but you still should be aware that they are there. First of all, we have our intercostal muscles. All right, our intercostal muscles. And intercostal, of course, means in between the ribs. So these would be the muscles in between your ribs. Okay, first of all, on the very outside, and it makes sense why it's called this, would be your external intercostal muscle. So your external intercostal muscle here. And notice that the fibers run in a transverse, or an oblique direction rather. In a direction, I like to say, as if you were putting your hands in your pockets. So the inferior border of that is the more anterior portion of the slant in the direction the fibers are going. And also notice that the beginning of the external intercostal starts back here near the vertebrae, and only goes about, doesn't quite go all the way to reach the sternum. Notice that there is a break in the muscle here. This is where it ends. And here would be simply an intercostal membrane that takes up the rest of the space towards the sternum. All right, so every external intercostal goes only about to where the border of the rib and the cartilage for the rib that attaches the sternum is. So then the rest is external intercostal membrane. All right, underneath there, you have the internal intercostal membrane. So underneath that, the internal intercostal muscle. So underneath the external intercostal membrane, you can see the internal intercostal muscle. And notice that that starts at the sternum and moves its way backwards and ends approximately the same distance to the vertebral column as the external intercostal muscles are to the sternum. And of course, then you have your internal intercostal membrane. Notice that's on the internal portion of the rib cage as opposed to the external portion of the rib cage. Now, just inside of that, you have another set of muscles called your innermost intercostal muscle. So external intercostal muscle, internal intercostal muscle, then your innermost intercostal muscle. And they follow about the same path as the internal intercostal muscles. So what's the purpose of these muscles? Well, they aid in breathing. The external intercostal muscles help to expand the rib cage, which will aid in inspiration or inhalation, whereas the internal intercostal muscles will retract the thoracic cage, the ribs, to help with expiration. So external inspiration, internal expiration. So exactly the opposite of what you think it would be. All right, externals for inhalation, internals for exhalation. And the same would apply to the innermost. They would help with the internal intercostals. Okay, other muscles that you'll see, and you notice they are small and in between ribs, so their role is not as significant as the ones we've already discussed, and that would be your subcostal muscles and your transverse thoracic muscles. Notice that the subcostal muscles are about 2/3 of the way around the rib cage towards the posterior side, whereas the transversus thoracic muscles are on the anterior side attached to the sternum. One more thing that I didn't point out earlier, but I do want to point it out now, is that with your rib cage, with your thoracic wall, you have your ribs and you have these muscles between the ribs, the intercostal muscles, but you also have this set of blood vessels and nerves that run along the underside of each rib in what's called the costal groove. All right, so here would be your costal groove right here, and they run very specifically. You have your intercostal nerve actually, let me do this a different way. You have your intercostal vein at the top, so your rib, your intercostal vein, then your intercostal artery, then your intercostal nerve. So if you want to know them from top to bottom, it's vein, artery, nerve. It spells van. So you have your van parked underneath your rib. Vein, artery, nerve. That's the direction that they run. So the importance of this is that, of course, the vein and the artery are going to give a blood supply to your muscles of the rib cage of your thoracic wall and take deoxygenated blood away, and the nerve is going to supply, the impulses to be able to contract those muscles. So when you're doing a procedure such as a thoracentesis, where you're putting a needle into the thoracic cavity, you always want to make sure that you go above the rib, not below the rib, so you don't risk damaging this vein, artery, and nerve, affecting the blood supply or the innervation to the intercostal muscles. Now you might ask the question, well, at the top of each rib you have these collateral branches. Well, those collateral branches are supplemental to the primary intercostal vein, artery, and nerve. And if you damage the primary intercostal vein, artery, or nerve, the collateral branches are not going to be enough to compensate long term. So better to damage the collateral branches than the intercostal vein, artery, and nerve. So always go over a rib. So as far as the blood supply to the thoracic wall goes, I want you to pay attention to the aorta here, because many of the branches going to the thoracic wall come off of the aorta. In particular, you have the posterior intercostal arteries coming off the aorta, going around the posterior side of the rib towards the anterior portion. And then you have another thing to pay attention to is the subclavian artery. Of course, that's coming off the brachiocephalic, which is coming off the aorta. And the subclavian artery supplies these two arteries and the anterior part of the thoracic wall. And those are called the internal thoracic arteries, also known as the internal mammary arteries. And we'll talk about that a little bit later on, I think. But those are going to give rise to your anterior intercostal arteries, which are then going to start in the anterior and work their way to the posterior. And at some point along the rib, the posterior and the anterior arteries will anastomose with each other. In other words, make connections to where you have a redundant blood supply. All right, and then one last artery to point out is this supreme intercostal artery, and that's going to be the one associated with rib 1. All right, so the supreme intercostal artery is rib 1, and then intercostal arteries are going to be associated with each individual rib underneath that. All right, when we're talking about veins, we always have to make sure that we understand that veins are draining the thoracic wall. They're draining the region or the organ that we're talking about. So the pathway is from the actual intercostal space to the major veins back to the heart so that it can be pumped out to pulmonary circulation. So we'll start that way, just like we did with the arteries. We have our, and I don't know why these aren't highlighted, but they should be, your posterior intercostal vein, of course, going from the rib along the posterior aspect of the thoracic wall, and then your, anterior intercostal vein coming from the ribs to your anterior portion of the thoracic wall. The anterior intercostal vein, of course, draining into the internal thoracic vein, which is the vein associated with the internal thoracic artery. And the posteriors are going to drain into the azygous vein. Azygous, of course, means unpaired. So it's only going to be located on the right half of your of the body of the thoracic wall. And then, of course, that's going to drain here into the brachiocephalic trunk, as well as the internal thoracic veins draining into the brachiocephalic trunk as well. And keep in mind that these brachiocephalic trunks drain into the superior vena cava, and of course that's going to go right back to the heart. As for the innervation, you see here that the spinal nerve is coming out just underneath the neck of the rib, and here you have your intercostal nerve that is running along the underside of the rib. And remember, we have the vein, artery, and nerve, so it is the last piece, so there's going to be spaces above it for the vein and the artery. And just like the vein and artery, yet I didn't mention this, the nerve, the vein, and the artery run in between the internal intercostal muscle and the innermost intercostal muscle. So they're nestled between those two sets of muscle, the innermost intercostal muscle and the internal intercostal muscle, so kind of protected by that muscular layer. All right, and the way they're numbered is if you look at this nerve right here, if this is the fifth thoracic nerve coming out, then this is going to be the fifth rib. So the nerve passes along the rib that it's associated with. Okay, then you have this posterior ramus that is going to the skin of the back, and then it branches off into this lateral cutaneous branch, which supplies nerve endings to the skin of the side of the lateral aspect of the thoracic wall. And of course, this lateral cutaneous branch that goes along the side and continues to provide innervation to the lateral portion all the way up to the anterior portion. The intercostal nerve runs around, pierces through the internal intercostal muscles, and then branches into the anterior cutaneous branch, will then supply the skin of the anterior thoracic wall with innervation. Okay, and these are going to be the bases for our dermatomes. So if this is, T5 coming out here, then this intercostal nerve would supply the T5 dermatome. Of course, given the fact that of where we are on the sternum here, I'm just making numbers up. That's not actually what really applied to this picture. But the point is that if this is vertebrae number 5 and this is spinal nerve number 5, then this is going to give rise to the fifth dermatome, the T5 dermatome. All right, so one of the activities in your bare bones book asks you to trace this spinal nerve from its root out to the dorsal ramus, which of course would supply the skin back here. Trace it around to the intercostal nerve, which would then pierce and have your lateral branches branching out and supplying the lateral posterior and lateral anterior regions of the thoracic wall. And then piercing, continuing around, and then piercing up front to supply the anterior portion of your thoracic wall or your chest and sternal region with that nerve. And again, just a reminder that the way it traverses is within this costal groove of a rib, and the way it's organized is you have your vein most superior, artery in the middle, and then nerve at the bottom. Notice I repeat this a lot, so that probably means this is going to be something important for you to remember. All right, so we've already talked about the veins that are associated with the thoracic wall, so we're not going to cover that in this slide, but I do want to point out the lymphatic drainage of the thoracic wall. And if you notice, the lymphatic drainage, you can follow them along the lymphatic vessels, but along the lymphatic vessels, you have these lymph nodes. So anywhere you see the lymph nodes, even if you don't see the vessels, you know there are going to be vessels that are helping to drain that region. And these peristernal nodes are what are involved in the lymphatic drainage of the anterior thoracic wall. And they run along the same pathway as the internal thoracic artery and veins, or the internal mammary arteries. You also have your diaphragmatic nodes, which it says that they are near the diaphragm, so that's going to drain the most inferior region. And then your intercostal nodes back here that are in between each rib, of course, and they're going to help drain the excess fluid from the spaces in between the ribs. All right, now an interesting feature of the thoracic wall, especially when you consider the female of our species, is the breast. And the breast is a collection of various types of tissues that perform specific functions, and all of which lead to the purpose of feeding a child once it is born. So notice that the breast sits on the most superficial part of the thoracic wall, just underneath the skin. So it's going to be sitting on top of your pectoralis major muscle here. So the breast is just underneath the skin. It's not under any specific muscles. Okay? And what it primarily contains, what makes up the bulk of it, is adipose tissue. And the adipose tissue provides both an insulation for the other structures that are within there. And also, of course, adipose tissue contains nutrients, so it also helps supply the nutrients to the mammary organs that are within there. So what are the mammary organs? Well, we have these lobes. Okay, all of these lobes that contain cells, exocrine cells that produce milk. They drain into these lactiferous ducts. All right, so they drain to these lactiferous ducts, which then form these lactiferous sinuses, where all the ducts come together, and then those lactiferous sinuses all converge onto the tip of the nipple. So if you were to look really carefully at the nipple of a female, especially when she's pregnant and expressing milk, you would be able to see little holes or little pores within the nipple through which all of these lactiferous sinuses are coming out and going to the surface. And of course, that's where the milk is going to come out. All right, so that's the nipple. And then surrounding the nipple, you have this areole, which is a piece of darkened skin surrounding the nipple. The typical location of the breast, or at least the primary tissue of the breast, is between intercostal nerve, or actually it's supplied by intercostal nerves 2 through 6. So that tells you that it's pretty much in between rib 2 and rib 6 right here. All right, and that's going to be true for all breasts. Breasts come in all different sizes, so despite the fact that some may hang lower than that, the origin of the breast tissue is going to be between ribs 2 and rib 6. Notice also that the breast tissue extends back here into the axillary region, which is, when it extends back there, it's known as the axillary tail, or in PE lab, you're going to call it the tail of Spence. It's an older term, but either work, the axillary tail or the tail of Spence. And that's really important because when you're teaching, when you are actually doing breast exams or you're teaching patients to do breast exams, not only do you want to feel around the primary area of the breast tissue, but you also want to go back there and feel underneath the armpit because there could be masses that are hiding in that tail of Spence or the axillary tail that you may miss if you're not checking back there. So very important to keep track of. For the blood supply to the breast, you have the internal thoracic artery, of course, that's running here, and that's going to supply blood into the medial portion of the breast. And then you have the lateral thoracic artery, which is going to supply blood to the lateral aspect of the breast. All right, so internal thoracic artery medial, lateral thoracic artery lateral, blood supply to the breast. Lymphatic and venous drainage occurs, let me erase this. Occurs radially outward, from the center of the breast outward, and the superior and lateral is going to be picked up by lymphatic vessels and venous vessels in the axilla, whereas superior and medial drainage, and of course some inferior too, is going to go to the lymphatic and venous vessels that are associated here with the internal thoracic artery, so the internal thoracic vein and the associated lymphatic vessels with that. So this is just another picture right here showing you again that radial nature of drainage, lymphatic drainage or fluid drainage, if you will, from the breast. And as it flows medially, you're not going to be able to catch those lymph nodes because they are deep. But as it drains laterally, you are able to palpate, and we'll talk about some of these nodes later on and why they're important. And you're definitely going to be feeling for them when you do your physical exam. You have various groups of nodes in your axillary region, and you would do well to start remembering what those nodes are because you will be tested on those, maybe in clinical correlations, but definitely in your physical exam. They'll be looking to see that you know which nodes you're feeling for and which nodes are located in those regions and which ones you might expect to be affected if you have a cancer or an infection in the breast tissue. So these pictures right here, it's just showing you again the ducts and the duct system emptying into the lactiferous sinuses and then emptying into the pores that come out the nipple. So just a little bit better picture, more high quality picture than was in the previous slide. So just take a look at that for a better understanding of what the anatomy looks like at the nipple level. And then another interesting thing that I wanted to show you is the breast tissue is held in place by connective tissue, and you can see this connective tissue just in front of I don't care that you know the names of it at this point, but this connective tissue that's just in front of the pectoralis major, and then all of these ligaments that are coming out and running in between the adipose tissue, whose job it is to basically hold all that tissue together and keep the breast as a single unit rather than as this gelatinous mass that could spread all over the thoracic wall. So these ligaments are going to be really important for maintaining the shape of the breast and keeping it connected to not only the thoracic wall but also the skin itself. So the breast is a really well developed, well encased organ within the thoracic wall. One final thing that I forgot to mention is associated with these lobes within each unit of glandular tissue, there are about 15 to 20 lobes that are geared towards producing milk. But out of those 15 to 20, only about 6 to 8 lobes actually are producing the milk and are functional within that unit. So there's a lot of reserve capacity for producing milk in the breast, and a lot of women, when they first get pregnant or have their baby actually and are breastfeeding, they're worried that they're not going to have enough to feed the baby. But given the fact that we have all this reserve, there's more than enough to actually provide adequate nutrition, and really important to get educated on and educate your patients on when they are pregnant and are considering breastfeeding. So that wraps it up for the thoracic wall. As always, if you have any questions or comments, please either email me, give me a call, or talk to me in lab, and I'm more than happy to answer them for you. Have a great day.